Hi, everybody. It's Mark Newman from Precision Analytical, the makers of the Dutch test. I am right in the middle of a video series I think you'll find helpful as we explore the answers to this little controversy within our industry, which is this: transdermal and testing. We know, this is undisputed, that when we use the types of doses people use in practice for testosterone, estradiol, we're going to be talking about estradiol in this video. What do we get? We get big increases in saliva, big increases in dried blood spot, and less of an increase, although a significant increase, in serum or urine with the same exact product. How do we make sense of that? I want to show you some data today that will help you understand this a little better. Let's start with serum. We're going to focus as much as we can on one product, estrogel. This is not data from estrogen gels generically. This is data from estrogel, okay? What we find is that the dose I'm pointing to there, the serum levels at the ultra low 0.27, they don't come out of the postmenopausal range. And guess what? They don't work. Delayed impact on vasomotor symptoms from the FDA studies. A nice study on vaginal atrophy that said this dose doesn't work. You need more. And when they used more, it did work, right? So it shows that's a low dose. Unproven for bone mineral density because they had to go up to this level, 0.75, to see some impact on bone, but let me show you that data. 0.75, and here's the control with no hormone. At 6 months, it wasn't enough. If you wanted impact on bones at 6 months, you had to use a higher dose of gel. Now, if you look at 12 months, yes, 0.75 worked, but you know what happens when you use a higher dose? It works at 6 months. Do you know what happens when you use 0.025 milligram of a patch? You get bone mineral density increase at 6 and at 12 months. What does it tell you? This dose of gel is just barely enough. It's not a ton of estrogen. It's a little bit of estrogen. And if you take the dose down, it'll also fail again for both vaginal atrophy and vasomotor symptoms. Now, what we find in serum, again, is that these low doses of around 0.5, 0.75, they're barely getting out of the postmenopausal range in serum. It's the same thing we see in urine. This data shows it's out of the postmenopausal range, not yet into the luteal range. That's a sweet spot for success with ERT. We presented this data last year at NAMS, which was a really great conversation. What we want to contrast that with is what happens if you take those same products. So this is the same estrogel product. This is the only published data in saliva. So remember, this dose puts you above the postmenopausal range, but not even into the luteal range in urine, and not into the luteal range in serum. So it's a modest dose. When we look at it in saliva, this is published data where they were just comparing two different gels, and what they found is you get moderately elevated data 24 hours after testing. Now that's where your next dose comes, right? So the pattern looks like this: up, down, up, down. So the lion's share of the time you spend on this product, your values are where you can see there. Now put these in context. Luteal values for this same testing system are around 5. A postmenopausal woman is less than 1 on average, and yet with this product, which we know isn't that much estrogen, you're literally 100 times luteal. 100 times a pregnant woman. That's how much estrogen you're seeing in saliva. So when we ask ourselves, is this representing tissue? Is this representing clinical impact? That's pretty interesting data. They did this on 5 women. All of them showed really big values in the hundreds, in the thousands, in the middle of the day in which they're supplementing, which shows you that estrogen is getting into the saliva at levels that don't seem to be showing up as it relates to bone, as it relates to vaginal atrophy. That's pretty interesting. If you want to know that those doses of gels are in fact, quote, low dose or low to medium dose, you can read these studies and they'll show you vaginal atrophy, hot flashes, bone, what happens with these doses. Now, here's some published data. This is not from peer-reviewed published data, but this is from the Townsend Letter, saliva data, dried blood spot data. I think this data is solid data, meaning this is what really happens in saliva on these products. And what it shows is with a very low dose of 0.1 or 0.25, that's a good dose to compare. Let's look at 0.25. We are outside the premenopausal range, okay? For blood spot, we are twice as high as a 0.05 patch. Now, 0.025 patch works. 0.05 patch, that's a decently hefty dose of estrogen. And what blood spot implies is that 0.25 of a cream is twice as much estrogen. What saliva implies is that compared to 1.3, that 0.25 of a cream is much more than a patch. Now, don't be confused by the dosing of the patch. There's like 4 milligrams of estrogen in the patch, but only a little bit of it gets in, and that's what they name the patch after. How much estrogen gets in. If you take 0.25 of a cream and ask yourself how much of it gets in, saliva and blood spot imply a ton of it gets in. Too much of it gets in, right? But when we look at the clinical data, we don't see a correlation there. So that ultra low dose increases the values a lot. What do we conclude from that? Well, it depends on what we follow. If we follow the urine data, it implies that the skin absorbs about 10% of a cream or a gel. If we follow saliva or dried blood spot, it implies that no, the skin really absorbs all of that estrogen. Right? That's really the way you would get those values if there was a one-for-one representation. If the model that we're building says that saliva represents tissue in this scenario, it would imply that almost all of it is absorbing. Now, when we look at dosing, serum or urine will imply that 0.25, 0.5 of a gel is a relatively low dose. Saliva and dried blood spot imply that 0.1 milligram of a cream is more estrogen than a 0.05 patch. Now, the number's higher, but again, 0.1 is how much you're putting on the skin. As to how much gets in, we don't really know, right? With the patch, this is verified as that's how much gets into the average woman is 0.05. That's a lot of estrogen, right? Saliva implies that 0.1 is more estrogen than that medium dose patch. It also implies that 0.75 milligrams is a monster dose of estradiol for a woman. And what we do with that to figure out which model is really telling us something closer to reality is, again, to look at that clinical data. You go read those papers on what happens specifically with those doses of estradiol. To me, it seems to imply that 10% of the estrogen getting in, that's about what the clinical picture says. Yeah, you're going to need to use 0.5 milligrams of an estrogen product to start to get some clinical impact. So you can look at the data for yourself, read the papers for yourself. I thought that saliva study, though, was really interesting that shows that in the middle of the day, 0.75 of a gel that's proven to be moderate in clinical impact is way higher in terms of the values you're seeing compared to even pregnant patients. So I hope that's been helpful for you as you explore this data and try to figure out for yourself which testing modalities are going to work best in a given scenario. Stick around for our other videos, and I think you'll find some other data that's really illuminating as it relates to this complex topic.